Welcome to the 6th episode of AngioPod, the podcast for vascular fanatics. Today's discussion is about thoracic aortic disease. We have Dr. Kuldeep Singh joining us along with Zachary Chadnick, our third-year general surgery resident. Thoracic aortic disease is vast. We have tried to make it as compact as possible so as to deliver key concepts about aortic pathology in this small episode. This is your host, AJ. Let's get started. Let's begin with some basic definitions. Zach, tell us what you understand about the spectrum of acute aortic syndrome.
So as you said, acute aortic syndrome is a spectrum of pathology, and this includes aortic dissection, intramural hematoma, penetrating aortic ulcer, and aortic rupture.
And what do you mean when you say intramural hematoma versus penetrating aortic ulcer or a dissection? What are some of the key differences amongst the spectrum?
So intramural hematoma is essentially when you have that thrombus on the wall of the vessel. The penetrating aortic ulcer is when you start having damage to the wall, and then aortic dissection is when you have blood flow going through the various layers of the aorta.
Yeah, I think one way to differentiate these three pathologies is if you have an actual tear that you see on your CAT scan, that is by definition an aortic dissection. The penetrating aortic ulcer is basically an atherosclerotic lesion that has an ulceration, and you can see that on the CT scan. An intramural hematoma, like you said, is a collection or a clot within the wall of the aorta, but it doesn't have any intimal tear that you can identify on the CAT scan.
Yeah, AJ, that's important to remember. Just because there isn't a tear, that doesn't mean that it's not present or you don't see it on a CAT scan. But an IMH and a penetrating ulcer, they're very similar. It's just with the penetrating ulcer, you see diffusely calcified wall. And in that one area, it's penetrated and obviously it's caused a little bit of a thrombus there and maybe a small rupture, which is now has been contained. That's similar to what you kind of see in like ruptured carotid plaque. A IMH, yes, you see that thrombus there, but it's not just a thrombus that's accumulated on the wall. It's accumulated for a reason. But it might be a focal area of calcification or even a small tear that you're just not seeing.
Yeah. So going forward, the classifications are extremely important because you need to identify what kind of dissection or acute aortic syndrome you have. So tell us about different classifications for aortic dissection.
The classifications are either DeBakey or Stanford. For Stanford, there's type A and type B. Type A involves the ascending aorta, and type B involves anything distal to the left subclavian. So basically anything involving the ascending aorta, even if it includes a descending, is a type A dissection. For DeBakey, there's type 1, type 2, and type 3. Type 1 is entry tear into the ascending aorta and extending into the descending. Type 2 is entry into the ascending and it's localized to only the ascending. And type 3 is entry into the descending as localized only in the descending.
Yeah, that's very good. Just remember, type 1 is everything. The entire aorta is dissected from the ascending all the way down to the iliacs. Type 2 is only the ascending, like you said. And then obviously the type 3 is going to be left subclavian and below. Often now what we use is the Stanford classification more often than the DeBakey classification. So we just say a type A or a type B. A type B is what we typically deal with, which is distal to the subclavian, and type A is going to be anything that involves the ascending.
Right. For the listeners and the young residents and medical students, when you're seeing patients with aortic dissections or acute aortic pathologies, just remember that the younger patients tend to have genetic aortopathies, whereas your older patients will have your typical vasculopath risk factors like atherosclerosis, as well as a history of hypertension, smoking, etc., which predisposes them to the dissection.
Yeah, very good. AJ, let me ask you about these type A and type B dissections and the management. What's the difference in terms of the management?
So it's very important to distinguish between the two because as we know from the literature, that's type A, the longer you delay surgical repair, the worse the outcome is. Whereas type B, you can wait on these patients as long as they don't have any signs or symptoms of malperfusion syndromes.
Yeah, that's very important to remember. Sometimes the type B looks scary and the patient presents in a severe chest pain. And often you may think, well, this patient needs to go to the operating room. So how would you manage that patient, somebody with a type B dissection, acute type B dissection, where they don't have malperfusion syndrome, but they do have severe chest pain or back pain?
Right. The goals of management of these patients is one, to get control of their hypertension. Most of these patients, they present with this acute onset of chest pain or back pain that radiates. And these patients are typically hypertensives above a systolic of usually 180s. So the key there is to manage the hypertension of these patients. Again, when you examine these patients and you get the imaging finding, is to make sure that the visceral segment as well as the peripheral vessels are well perfused and there is no indication of malperfusion, because that will change the management. For medically managing these patients, you have to use something that gets control of the systolic blood pressure as well as the pulse pressure. And those can be achieved with beta blockers. So like an esmolol infusion or a labetalol infusion are actually the drug of choice of managing these patients in the ICU. All patients have to get admitted to the ICU. They need invasive arterial monitoring. They need these antihypertensive medications in a drip. Apart from that, they have to be monitored for malperfusion that may develop after admission. So regular vascular checks in the extremities, as well as checking them for stroke, because you can have retrograde dissection that can involve the carotid as well as the subclavian vessels. And then the serial abdominal exams to make sure that the viscera are well perfused. The kidneys need to be monitored because you can have a dissection that extends into the renal vessels that can cause malperfusion of the kidneys. So regular serum creatinine levels as well as the urine output should be carefully monitored. And all of this can be achieved in the ICU.
Yeah, so it's important to remember once these patients come in and you get their blood pressure under control, typically in the ICU. After that, before discharge, we usually get another CAT scan to make sure that there's no extension of the dissection, either proximally or distally, and also to make sure that malperfusion type of syndromes are not occurring.
Dr. Singh, what about the concept of static as well as dynamic malperfusion?
Okay, so a static malperfusion is typically an occlusion of a vessel. Let's say a true lumen has been compromised so much because the false lumen has gotten so dilated that it obstructs one of the, let's say, the renal artery. So that's called a static malperfusion. A dynamic malperfusion is typically occurred when the false lumen partially covers a vessel, and with the blood pressure, it sort of obstructs it sometimes, and then, but it's not complete, and may wind up opening it. So it sort of goes back and forth, almost like a door.
Yeah, that's a nice explanation. And also, it's easier to review these with imaging, which is hard to do on a podcast. So definitely recommend checking some of the videos as well as the pictures out there in textbooks to understand this concept.
Yeah, speaking of imaging, AJ, what do you think is the ideal image for these type of dissections?
The ideal image for aortic dissections is to get a fine cut that is 1 millimeter slices, CT angiography of the chest, abdomen, and pelvis. And this is because you want to include the ascending, the arch, as well as the descending aorta, all the way down to the iliacs, as well as the femoral vessels, so you can see how far the flap extends, as well as get a good view of all the branches of the aorta that come off of it.
Yeah, very good. So before we forget, you talked about type B dissection and how to manage it. Typically, medical management is the first thing that we do. Do we always do these medical management? When do we operate on type B dissections?
Okay, I think before we get into that, let's talk about how we identify false as well as the true lumen, because you guys keep bringing it up during the conference and half the residents, they have this blank stare and they have no idea what you're talking about. So Zach, why don't you tell us how you identify a false versus a true lumen on a CT angiography?
There are a couple of ways to do it. Some people talk about tracing it back, but I think the easiest way is that the true lumen is always smaller, and that the pathophysiology of this is that because there's no muscular layer in the false lumen, it protrudes into the true lumen.
And another key aspect when looking at the CT angiograms is to make sure you identify what visceral vessels are coming off of the true as well as the false lumen, because that is how you're going to plan treatment for these patients.
Yeah, an easy way to remember that or conceptualize that is, you remember the aortic wall is made of the intima media and adventitia. So when you make a tear in the wall, the adventitia starts to sort of buckle out. There's not much holding it in place. It's the only layer that's there. So you have 3 layers, which would be the true lumen, versus that 1 layer, which is a false lumen. That 1 layer is basically paper thin. So of course, it's going to balloon out a lot more Yeah, another important thing to remember is to look at fenestrations. You want to make sure distally that there are holes that are perfusing the vessels. If you plan to treat this proximally, then you may shut off the false lumen, and some vessels that are coming off the false lumen can potentially occlude. This is a very complex pathology, and you have to have a lot of experience when you're dealing with this, especially if you're planning on repair.
So patients that have a type B dissection, which is uncomplicated, and by uncomplicated, I mean there is no malperfusion, the pain is resolved with medical therapy, and their critical diameter is less than 5.5. These patients, you typically want to repair electively in 2 weeks, and that is so that you can allow for aortic remodeling and you can size your grafts for endovascular repair appropriately. Then there are certain patients that will not respond appropriately to medical management, and these are patients that either develop malperfusion or presented with malperfusion, have persistent pain despite having good blood pressure control, and have a critical diameter of more than 5.5 centimeter, or a rapid expansion. So those patients, they meet a criteria for urgent repair.
Right. So that's also another important reason to get a CAT scan before these patients go home, because you're talking about an expansion over a year, but they can also have an expansion over a few days. So before you discharge these patients home, you want to make sure that the blood pressure is controlled and that dissection is not getting worse, which could be another indication to repair sooner than later. Now, when you do repair, how long do you typically wait?
You wait about 2 weeks to allow for appropriate aortic remodeling.
Yeah, that's important to remember, because with this acute dissection, you have this tear in the wall that leads that wall to be very, very thin. So if a patient just walks into the ER and you think you're going to go ahead and start putting wires and catheters up there in that friable aorta, you're going to have a lot of problems. So you do want to wait. You want to get the blood pressure controlled, and you allow for that dissection to essentially become chronic after 2 weeks. It's traditionally considered chronic after 2 weeks. So it just allows it to be a little bit more rigid and a little bit easier to work with.
I have a question for you, Dr. Singh. I think when I was a medical student, I believed that you could just leave the type B aortic dissections taken care of the acute phase and just manage the blood pressure. So what changed in the last 7, 8, 9 years where now we do electively repair all of these aortic dissection cases?
Well, that's not exactly true. We don't always electively repair these. There are still some that believe that we should not repair these and we should leave it alone. But essentially what you're talking about is a few trials that came out. One big landmark trial was called the INSTEAD trial. The INSTEAD trial essentially looked at aortic dissections and separated these patients into patients that underwent repair after 2 weeks, covering of the entry tear, versus patients that only underwent medical management. And they looked at these patients over time, approximately 2 years, and they realized that there was no change in overall mortality. Overall mortality for both groups was roughly 90%. So that basically told you that there's no indication to repair these patients if you're going to have the same mortality rate out at 2 years. But that when they looked at these patients the longer term, and this was the INSTEAD XL trial, when you look at them after over a 5-year time period, there was a slight difference. What they noticed is that patients that underwent endograft repair versus the medical management group fared better. They had a aortic specific mortality approximately 6% versus 19% compared to the patients that underwent medical management. Now, when you look at disease progression, in other words, if you want to look at what happens to these dissections, do they get larger over time? Do they become aneurysmal? Well, that also was a difference. So patients that underwent an endograft repair had a lower aortic disease progression compared to the medical management group. So this was in a 5-year time period. So this is the INSTEAD XL, and the first trial that we just talked about was the INSTEAD. One looked at 2-year time period. The second one looked at a 5-year time period. So when you look at it in the longer term, it seems that patients that undergo recovery of the entry tear overall may fare better in 5 years.
I see.
Okay, Zach, let me turn it over to you. Tell me a little bit about type A. We don't deal too much with this because we typically call our colleagues the cardiothoracic surgeons. But how do you treat a patient with a type A dissection?
Yeah, so type A is always always requiring surgery. So the only indication for medical therapy is basically as a bridge to the urgent surgery to stabilize the patient, get them into the operating room. The concern about a type A dissection is basically you can get retrograde dissection going into the pericardium, causing pericardial tamponade, and it can actually involve the coronaries as well, leading to coronary dissection, which is why these always need to be repaired as soon as possible.
Yeah, that's very good, Zach. So you talked about a retrograde dissection involving the coronaries. That's not the only complication of retrograde dissection. You can also have involvement of the head vessels as well, which may cause strokes. And the type of operation that's required, it all depends on the anatomy and may require replacement of a root, like a Bentall type of procedure, or an elephant trunk, but these are more cardiac based, and that's not typically something we get involved in. So we don't need to know too much about that, but a picture is worth 1,000 words. So it might be worth it to just Google one of these images, and then that'll show you exactly what procedures that I'm talking about.
Yeah, Dr. Singh, I tried to Google these procedures and I'm not any wiser after that.
Is that right? Well, okay, just know how to treat what you need to treat distal to the left subclavian. You'll be okay.
Yeah, I think I'm going to stick to that.
The other thing is, AJ, though, you do have to know how to treat a type B dissection. So when we're talking about treatment of the entry tear, remember, typically the entry tear, it occurs distal to that subclavian. So what you need to do is get into the true lumen. You're going to have two lumens, a false and a true lumen, and this can be a little challenging. So it may require some skill, but you need to get a wire into that true lumen from the uninvolved iliac or femoral vessel. Once you get that wire up, you have to make sure that wire is in the true lumen and then past that entry tear. Over that tear, you can place an endograft, and that should cover that entry tear. So now the blood will be rerouted all into that true lumen. But the complication with covering that entry tear is that you may occlude that false lumen immediately, and that can lead to a malperfusion type syndrome because, remember, you don't know exactly what vessel is coming off of which of the lumen. So if a vessel is coming off the false lumen is occluded. Now that you're going to have an occlusion of that vessel, and you may have to create a fenestration somewhere else to keep that false lumen perfusing.
Oh, I see. I just came up with a question. I think Zach can take this one. Let's say you have a type B aortic dissection. It's very close to the subclavian and you might end up covering the subclavian. What are some of your options of treating this patient?
So the only thing I can think of if you cover the subclavian is you can do like a carotid subclavian bypass.
Yeah, that's what I was getting at. So there is an option to perfuse your subclavian through the carotid. Dr. Singh, what about the use of IBIS for treating these complex type B dissections?
Yeah, I think that's essential. The more information you have, obviously, the better. So the more technology that you can use to isolate your true lumen, the better it is going to be for you. So an IBIS will give you an idea about which lumen is true and which one is false, especially if you have wires up on both sides in a true and a false lumen. An IBIS can give you a pretty good idea. It can also give you a good idea about the origin of the subclavian and give you a precise landing point for your stent.
Yeah, for the medical students, IBIS is an intravascular ultrasound. I forgot to mention that earlier.
An IBIS is also important. AJ, if you're doing things like fenestrations, I think it might be tough to talk about these without actually drawing these out, that if you need to fenestrate the tear distally. So basically what I was saying earlier, if you cover the entry tear and now you occlude the false lumen and the vessel that's coming off the false lumen, you need to perfuse that. You need to make some sort of a hole or something between the two lumens. So you need to fenestrate that septum that's there, which can be very challenging, but an IBIS can help you out with that as well. Other options are if you're causing a malperfusion type of a syndrome, is you may have to just place a stent in one of the vessels, let's say the renal artery, to keep that vessel open. This may be true if you're having a dynamic malperfusion. So an IBIS is essential when you're treating dissections. Yeah, an open option is not great, but then again, neither is an endovascular option. These are very challenging. So typically these patients, you likely will have to place them on a bypass machine to do this operation, depending on where the dissection is. If it's very proximal and you can't get control of it, you may even have to go into the chest to get proximal control. You can open up the aorta and just do an open fenestration and make sure to perfuse the vessels that were being malperfused. Other option is you may have to replace the entire aorta with a Dacron type of graft and then reimplant vessels. But again, very challenging because the dissection can go into the vessels itself. So if that happens, then that's a bad situation if you have a dissection going all the way into the, let's say, SMA or into the renals. AJ, let me give you a scenario. Let's say a patient comes in and they have a type B dissection. They don't have visceral malperfusion. However, the dissection goes all the way into the iliacs and you have an occlusion of the left iliac artery. The true lumen is into the right iliac and there's a good pulse in the right iliac. How would you manage this patient?
There are multiple options to manage this patient. One of the options is to do a fem-fem bypass and get perfusion of that left limb. The other option would be to try and fix the dissection flap endovascularly, create a fenestration so that there's reperfusion of the left iliac.
Yeah, that's a very complex option. So the first option is probably the best option, a fem-fem bypass, and then get the blood pressure under control and try to turn this acute dissection into a chronic dissection, and then you can manage it later on. Okay. Another scenario is if a patient is having, let's say the SMA is involved and you do feel a pulse in the iliac. So a very similar situation, which I gave. The iliacs are involved, but there is no occlusion of the iliac, but there is malperfusion in the SMA. How do you treat that patient?
So there are endovascular options to treat these patients with SMA malperfusion. The first step is to identify whether the SMA is coming off of the true lumen or the false lumen, and the type of malperfusion, static versus dynamic. And one of these options, if there is only thrombosis or a static obstruction, is to thrombolize it. Some of these patients might need a placement of stent through either the true or the false lumen, or you might need to create a fenestration in the dissection flap and stent the SMA through that to make sure that you're getting perfusion into the SMA.
Okay, let me just change that scenario on you. You're in a small community hospital where you don't have much access to endovascular devices, IBIS machines, and to be honest, you're just not that comfortable handling these type of procedures. You don't see that many in your hospital. What's an easy fix for this type of situation?
You can do a retrograde iliac to SMA bypass.
Yeah, that's exactly what I was looking for. So if you're stuck in this type of a situation, the way I see it is feel for a pulse. If you feel pulse in the groin, that's a very good target. So you take the bypass off the iliac and you can go ahead and perfuse your viscera as you need to. And then at least that will get the patient out of trouble. And then you can figure it out after that. Or if you're in a small hospital, you may need to transfer this patient to a bigger institution that has more experience with this type of situation. Let's move on to aneurysms. I think we've covered dissections pretty well. Why don't you tell us about the classification of aneurysms, AJ?
So the thoracoabdominal aneurysms are classified according to the Crawford classification. There are 4 types, but some places will also have a 5th type. Type 1 extends from the origin of the left subclavian to the suprarenal abdominal aorta. Type 2 extends from the subclavian to the aoroiliac bifurcation, essentially the entire thoracoabdominal aorta. Type 3 is a distal thoracic aorta to the aoroiliac bifurcation, and type 4 is limited to the abdominal aorta below the diaphragm. The type 5 is an aneurysm that extends above and below the diaphragmatic hiatus, and is pretty much limited to the visceral segment of the abdominal aorta with some extension into the thoracic aorta above the diaphragmatic hiatus.
Yes, very good, AJ. Yeah, it's kind of complex to remember these classifications, but you did a pretty good job. So Zach, when do you treat these aneurysms?
So typically treatment when the size is above 6 centimeters or there's growth of above 1 centimeter per year, or if the patient's symptomatic. But from my understanding, a lot of surgeons even wait a little bit longer because the procedure could be so morbid that you want to make sure that the patient is going to have a good enough lifespan and quality of life to benefit from the procedure.
Yeah, that's very good. And so what about imaging studies? What do you want to use?
For imaging, CTA is the modality of choice, and it helps classify the aneurysms as well as plan for therapy. And the key points in imaging are the size, the landing zones, branch vessel involvement, involvement, and then the lumbar and the intercostal arteries as well.
Right. So AJ, what about repair?
Repair options, there are endovascular, open, as well as hybrid options that are available. These patients that have like the type 2 extent, which is an extensive thoracoabdominal, may require the patient to go on a bypass machine for proximal control. They need the big thoracoabdominal incision that extends from the chest all the way down into the abdomen. And then using the clamp and sew technique, you do your proximal anastomosis and then reattach each visceral branch or use a Corel patch to attach the visceral branches onto this tube graft that you're going to replace the aorta with. There are other options that can be used for the smaller aneurysms. And these are the hybrid debranching options where you can do a retrograde iliac to visceral bypass and then use one of the endovascular devices to cover the entire aneurysm if you have good landing zones, both proximally and distally.
Yeah, exactly. That sometimes can be an easier option, but not always. It can be tough to get to that right renal artery when you're doing a debranching procedure. So what are the risks when you're doing this large procedure, replacing the entire aorta?
So the risks are related to obviously the acute intra-op process. The patients can get MIs as well as can go into acute pulmonary edema or heart failure there and then. And then you have the ischemia time to the renals, the visceral vessels, as well as the lower extremity. And that's why the bypass kind of helps maintain that perfusion while you go ahead with the repair. Even then, the renals, when you're reimplanting them, there is that a certain time that the renals are ischemic. So renal failure is another big one. And I think the most morbid out of all of these will be the spinal ischemia, which can leave these patients paralyzed.
What are the options to prevent spinal ischemia or not prevent it? I guess no matter what adjunctive therapies you perform, sometimes these patients still wind up with spinal ischemia. So, but what are some of the things that you can do to hopefully decrease that risk?
Right. So a multimodal approach should ideally be used. We use a spinal drain to monitor the CSF pressure in the spine during the surgery. And the ideal pressure in the spine should be kept below 10. This allows for perfusion of the spine during surgery. The other option is to reimplant large intercostal vessels back onto the tube graft that we're replacing the aorta with. And this will maintain the antegrade flow. Some other adjunct procedures that can be done are maintaining the mean arterial pressure higher and of a higher level of preoperative hemoglobin to allow for adequate perfusion during the surgery. Despite using all of these techniques, there is still a chance that the patient may have spinal ischemia.
Yeah, there's about 10% risk of spinal ischemia. So what we typically do here at Staten Island when we've done these procedures, we do an ax by fem graft. We don't tunnel the graft, we leave it outside, and onto the side of the graft we sew another graft, and through that graft we put multiple shunts in there. We use these shunts to perfuse the viscera as well as the lumbars, if the lumbars are large enough, during the time of clamping. So that does seem to help a lot. It does seem to prevent the post-op inflammatory response that patients get with a prolonged ischemia of the legs, of the renals. So we have seen pretty good results with that as well. But like you said, despite all of those measures, there's still a risk of spinal ischemia. Right.
And the spinal ischemia can happen after an endovascular repair as well, since we cover all the numbers.
Yeah, absolutely. Yeah, that is true. And that's a good reason to always put a spinal drain when you're dealing with a lot of coverage of the aorta. So let's say a patient's had a previous thoracic aneurysm repair, and now you're going to repair the abdominal portion. That's a good indication to put in a spinal drain.
That is it for our 6th episode. I hope you guys enjoyed it. Do support our podcast by sharing it with your friends and colleagues. And thank you for listening.